for this discussion, which I believe is deeply important and impactful. Our panel today will focus on children and racism in global health and the issues that affects millions of children worldwide, but a conversation that is hardly ever had. Unfortunately, when we talk about racism in health, it's often framed in terms of broader populations, which leaves the unique pathways through which racism affects children. Children, who are among the most vulnerable in the society, often bear the brunt of systemic inequities, and their health outcomes can reveal much broader embedded racism in global health. You are all, I'm sure, familiar with a lot of data in this regard. But let's just look at some of the key telling indicators. If you look at it from a perspective of disparity in child mortality rates, one of the most telling indicators, the data from WHO and UNICEF show that children from marginalized ethnic groups, particularly in low and middle income country settings, face disproportionately high mortality rate. In the United States itself, Black infants are over twice as likely to die before their first birth as compared to the others. Access to vaccines, another indicator to show the wide-ranging disparities. One of the things that we know in countries from India to Brazil and even in the wealthier nations, children from indigenous, Black, and other marginalized communities are less likely to receive vaccines in time, leading to preventable outbreaks such as those related to measles and polio. If you look at it in context of environment and environmental racism, we look at the data to be very telling. It shows us that environmental impacts disproportionately expose children of color to environmental hazards, leading to long-term health consequences in many African American and indigenous communities in the United States, for instance, and across Africa and Latin America. Children are exposed to higher level of pollution, unsafe drinking water, and poor sanitation conditions. The example from Flint in Michigan is a notorious example showing the kind of disparities that we are talking about. But this does not stop there. If you look at it from a perspective of mental health and trauma, racism clearly shows does not only affect physical health, but also mental health of children. Studies have shown that children who experience racial discrimination, either personally or through witnessing it in their communities, suffer from higher levels of anxiety and depression and post-traumatic stress disorder. These are just examples to illustrate racism in global health is not just a policy issue. It's a daily reality that affects lives of millions of children around the world. The question that I will be asking the panel and to you all is, so what can we do? We have an esteemed set of panelists whom I will introduce in a moment, who will help us explore actionable solutions from tackling institutional racism in healthcare systems to empowering marginalized communities to advocate for their health and rights. To move forward, we must acknowledge that structural racism isn't just a backdrop that we are talking about. It's a public health crisis in and of itself. As I said, we have an esteemed panel of experts today joining us. But before I introduce you, you will recognize that there are two people missing on this panel. One who unfortunately could not travel because of some travel restrictions, that is Senator Kibwana, and another colleague who could not join us today because of poor health. We are delighted that we do have the Regional Director of World Health Organization, Southeast Asia Regional Office, Dr. Saima Wazid, who has very graciously agreed to step in at the last minute, not just because she's a friend, but also because she is committed to looking at issues related to mental health and trauma amongst children and young people. Really grateful to you, Dr. Wazid, for joining us today. We also have with us today Professor Delan Devkumar, who is a professor of global child health at University College London and also the chair of the Lancet Commission on Children and Racism. Towards my right, I have Professor David McCoy, my former colleague from United Nations University Institute on Global Health, and who has worked extensively looking at issues around inequalities and inequities in context of global health, and has immense experience looking at these issues in context of apartheid in South Africa. And last but not least, we have Alejandra Cardenas, who's a lawyer by profession from Center for Reproductive Rights and a Colombian by nationality, and who will be talking about the experiences that she has had in looking at these issues in terms of maternal and child health. To begin with, I'm going to turn to the panel, and starting with you, Dilan, to share your initial reflections about intersection between racism and children's health. Over to you.
Thank you very much, Rajas, and thank you for inviting me and also for holding this session. Outside of certain contexts, I would argue that racism is barely considered as a global health threat. So having this session at all, and then one that focuses on children, and having it up front in a big conference like this is important. So in our previous work, we did a series on racism and xenophobia discrimination, which was published in The Lancet in 2022. I had three main goals in that work, and that was, one, to first consider racism as a health priority. This is an important topic that affects people everywhere. Second, to think of it as a global health concept. The same kind of thing is happening around the world in terms of caste, in skin color, ethnicity, race, religion, migration status, indigenous status. And thirdly, it's a structural issue, as you say. So we tend to think about racism on an individual level, interpersonal racism, but really the main causes lie elsewhere. I'm leading a Lancet Commission on racism and child health, and I obviously think this is an important topic. But Lancet Commissions, they tend to bring together experts, around 20, to work on topics such as this. And the first thing that we do is try to think about why we're doing this work. And I think there are three main reasons. One is that racism is a big determinant of child health, as you've been mentioning. It's important. We describe the interpersonal ways to the structural ways in which racism leads to health outcomes. But what I want to do is really to try to mainstream racism. There are people who work on racism, people who think about it, act on it, people, I guess, such as yourselves. But really, racism should be in all the conversations around health and global health. Every clinician, policymaker, researcher should think about this and incorporate racism into the work that they do. Secondly, within these conversations, children tend to be ignored. Racism is largely focused on adults, and I would argue that the impact is, if not greater, amongst children. There are the immediate impacts, but also these longer-term consequences. What happens in childhood can present much later in life as well. My colleague, Professor Naomi Priest, has recently updated a systematic review on racism and child health. They found 463 articles, and there's been a big increase in the last few years, which is showing the extent of the problem. But this is very geographically confined. Going back to my previous point that racism is a global health issue, 83% of those articles were from the United States of America, only 7 from low middle income countries. And even that, 4 were from South America, so there were 3 from all the other countries. So I really think that racism is a big problem, and there should be this kind of replication of work throughout the world. And then finally, interventions. And I'll come back to this later, but interventions tend to work better with children. We need to apply a complex system approach, think about why interventions work, why they don't, and then intelligently target those and apply a longer-term time frame. And finally, for interventions to work, we need to talk to children. We need to learn from children. Racism is about stories. It's about stories that humans tell themselves, stories that divide, stories that motivate one against another, that place one group above another, that lead to violence, to exclusion, to the poor physical, mental health outcomes. But children are not born with these prejudices. They can change the stories, and the fix to racism lies in that next generation. Thank you.
Thanks a lot for that, Dilan, and for emphasizing not only the kind of the veracity of evidence that is starting to generate, but also the need for us to look at interventions and also look at it from the perspective of telling the story and how we do that. Before I come to you, Dr. Basit, and just a statement to our audience here and also online who are joining us. This is a session that is being live streamed. Do get your questions ready. This is an interactive dialogue. We'll have the panelists present some of their reflections, but then it's over to you to hear from you and your experiences, and also how you think we can take this conversation forward. But with that, over to you.
Thank you. It is such a pleasure to be here. I mean, one thing I should say, friends always take advantage of you. I just wanted to attend the session and look what happened. But it is really a pleasure to be here and to be speaking on this topic. Professionally, before I became regional director, I was an autism and mental health advocate. Prior to that, and I still am a licensed school psychologist. And I used to work in the US, in Florida, and all of my schools were majority minority groups of people. So this is, children and the racism that they face throughout their life within school systems, within health system and healthcare is something that I've witnessed firsthand. And let me start by saying, as a mental health professional, I can tell you none of our assessment mechanisms for mental health and disabilities are really designed or have been developed considering the race and culture of the child. So there is just starting off a straight up bias in the system. And that, as you had just mentioned, perpetuates throughout the healthcare system. We don't really have sufficient data and parameters for people like me who grew up in, considering not being considered as mainstream cultures. In South Asian countries, even if you look at age and height, we always think of this as average. That is not average for us. So none of the health parameters and measurement tools for even adults are based on groups that belong to different races. Now add the fact that when it comes to children, they aren't able to communicate. So that racism then perpetuates even more. And it is something, I'm so glad that this session is happening now and that we're discussing it, because, we all see it, we all adjust to it, but if a system is not in place to account for what somebody's cultural background is, what is their communication style, what is their behavior, health behavior, we're not going to be able to respond to them and give them the right kind of guidance. So first comes the assessment process. So what would be culturally appropriate? What is the family structure? How do we, when it comes to health of children, we're not talking to the children. We're talking to the parent, the mothers. So is the mother understanding what the purpose of this question is? And if she's answering, what is she answering from? From what frame of reference is she answering? Those things are not considered. And this is the sense of embedded racism that exists. We're a global community. And in no country in the world can we say that we do not have minority groups. And so we have this global misconceptions that we, continue to perpetuate. But then even with that, within countries, you have micro racism, because we have minority groups within cultures. And the more they are smaller in numbers, and not part of the majority group, the more there's a bias already set against them. So there are many aspects to impacting health, impacting well-being. In the Zero region, we've therefore prioritized, we've developed a roadmap for resilience, and particularly looking at these vulnerable groups, particularly looking at children's health. Because even with, when we look at a health system and we're really not even looking at children per se. Our, if you have little babies and you think about their vaccination programs and how it is designed and when it is scheduled around what the health professionals' needs are, not so much what would be that child's needs and the child's experiences. So there, and then when you have the minority groups, when you have, for me, racism is also when you're in the extreme, living in extreme poverty, there's a bias and attitude towards them. They are also marginalized. So I think overall we have to look at how we are analyzing the data. Our baseline data are not reflective of them. The healthcare system that are in place are not with them in mind. Even research on medications, what would work. Is there a difference? Do we have an answer to the question? If we don't have an answer to the question, does it make a difference in how a medication or treatment methodology, how well would it work? So yes, I'm looking forward to a lot of questions, and glad to be here.
Thank you so much for that, Dr. Wazid, and really appreciate you making the point about the multiple intersecting forms of discrimination that children tend to face, but also how deeply embedded it tends to be in the system. And something that you mentioned, which I hope other panelists and colleagues and the audience will reflect on as we move the discussion forward, is how that experience of racism, whether it is perceived or explicit, conditions the trust in the healthcare system overall, and an individual and their society, their community, to access healthcare goods and services. David, can I come to you next for your initial reflections on how racism interacts with children's health? Over to you.
Sure, thank you. And let me just first begin by echoing what Dylan said about the importance of this topic, both the topic of racism, but also the topic of child health. Now, it's almost 30 years, in fact, it's more than 30 years since I was working in a pediatric ward in a rural hospital in South Africa, full of children with marasmus and kwashiorkor, in this country that was rich and wealthy. And I guess South Africa and the apartheid system is a really explicit and florid example of how racism can be baked into the social, political, and economic structures of a society to allow one group of people to dominate and subjugate another group of people in order to be able to exploit and misappropriate wealth and resources. So racism is something that is very dear to my heart. But at the same time, what I want to do in this conversation, Rajat, is really to think about how we combat racism and how we design our anti-racist struggles in a way that complements a wider struggle against socioeconomic and class divisions and divides. And South Africa is instructive in this regard. 30 years post-apartheid, infant mortality rates have declined, but they're still high. 1 in 5 kids grows up stunted. Inequalities between racial groups have declined, but inequalities within racial groups have grown. And inequalities at an aggregate level have also grown. So South Africa still has a political and economic structure and system that remains unjust, exploitative, and oppressive. So I suppose the reason for bringing this up is to consider how we can conduct struggles against racism in this context of, in South Africa, a society that remains divided by class. And if we look globally as well, the biggest cause, the biggest killer of children is still poverty. And we have, over the last 30 or 40 years, the development of economic and political structures that become globalized, in particular, that have perpetrated a further extension of inequality. The amount of wealth and power that is concentrated amongst a small elite, a transnational elite, has grown over these last 30 or 40 years. And although extreme poverty has declined, overall poverty any kind of decent measure of poverty has actually grown. Number of people living in social and economic precarity has grown. And unfortunately, these numbers are only likely to get bigger as the environmental crisis that we face begins to bite. So I'm trying to understand how we understand this in the context of the anti-racist struggles that we need to fight. And some of the work that we've been doing at the United Nations University is to reconfigure our understanding of colonialism in the sense of a contemporary form of colonialism that is largely driven through corporate and financialized structures. A neoliberal, globalized political and economic system that has not only increased inequalities, but has also driven the environmental catastrophe that we are facing. So what has this got to do with anti-racism? I think we have to design our anti-racist struggles very carefully, very thoughtfully, because I think there is a danger that we can construct anti-racist struggles in a way that reinforces an identitarian politics, that actually creates more social division, in a way that undermines our appreciation of universal values that are common to everyone, common to humanity. And also the danger of constructing anti-racist rhetoric and dialogue that can also inadvertently support and enable the emergence of authoritarianism, ethno-nationalism that is dividing the world, and rising risks of fascism as well from emerging. So for me, the challenge we have, Rajat, and everyone here, is how do we, as public health scientists, who can recognize that there are racial disparities in health, combat that racism, reduce those racial disparities in health, but at the same time build the solidarity that is required across these socially constructed racial groups that exist, that reaffirm the universal principles that are represented in the UN Charter and the Universal Declaration of Human Rights, so that we can be both particular about racism, but also universal about our common humanity.
Mm-hmm. Thank you.
Thanks.
Thank you. Thank you for that, David, and very well said, and not just, bringing in the point about intersections between racism and other forms of inequalities, but also the imperative of us looking at solutions that are multifaceted, right? And as Audre Lorde famously said, we don't live single issues life. So our struggles are multiverse and multi-issue. So our solutions have to speak to those challenges as well. And I hope we come back to some of those issues as we move this conversation forward, because indeed we cannot talk about these issues without addressing challenges of neoliberalism, coloniality, and its new manifestations as we are witnessing. Alejandra, over to you for your reflections, and now coming in from another continent and its perspectives.
Thank you, Rajat, and thank you, colleagues. It is a pleasure and a privilege to be in community with you all for the next 3 days. I want to just say that I applaud and I agree 100% with everything my colleagues have said. All forms of racism manifest basically in 3 dimensions, right? There's the institutional and structural, the personally mediated, and the internalized, and they are all intertwined. But the part I want to bring to the table today, or bring light to, is the impact of intergenerational trauma that begins in early childhood and its connection to maternal health. Something that medicine and science have proven over the years is that our bodies, our minds, our emotions are connected. And the psychological impact of discrimination translates into negative health outcomes that accumulate in us even before birth. In a study of over 2 million pregnancies across 20 high-income and middle-income countries, show that neonatal death, stillbirth, and preterm deliveries were significantly higher and more likely among babies born to Black, Hispanic, and South Asian women. The effects of race and ethnicity on preterm birth and small for gestational age babies did not vary across regions. In lower income countries, in places like Latin America, we're seeing the same disparities and sometimes even worse outcomes. Study after study keeps bringing light to the issue of obstetric violence and how racialized it is. This is a global issue. Babies born to racialized women, and Black women in particular, had consistently poor perinatal outcomes. Take low birth, for example, low birth weight carries breathing problems, infection, neurological problems, and can lead to long-term complications and disability. We know that experiencing racism causes chronic stress, and that prolonged exposure to stress hormones such as cortisol leads to inflammatory reactions that predispose individuals to chronic disease in life. And although children and adolescents are the targets of racism experience the most significant impact, bystanders are also adversely impacted by racism. There have been studies showing that bystanders in racist interactions' psychological and physiological effects are comparable to those experienced by first responders after a major disaster. Caregiver experiences with racial discrimination have been associated with depressive symptoms in their children and associated with lower ratings of psychological well-being in adolescents. We cannot talk about this issue and separate what happens to mothers and caregivers with what happens to their children. And the reality is that racialized women around the world start their journey to motherhood in a very traumatic way. And this has a tremendous impact on their children. My invitation is then that when we think of how to address racism in children's health, that we do not leave out maternal health. And in thinking about maternal health, my invitation is that we move beyond the paradigm of privacy and into a paradigm of agency. A paradigm of agency within a reproductive justice and human rights approach. And that means, and it requires, that we change the structural conditions that make access to quality healthcare so inequitable. Thank you, Raja.
Thank you. Thank you so much, Alejandra. Well said, indeed. And I would not try and repeat everything you said, but thank you for bringing both the point about the intergenerationality of impact that we are talking about, but also what the relationship between maternal and child health outcomes. I will go to the panel for one more round of question, and then it's over to you for your questions, reflections, comments, as you may wish. And maybe I can come back to you, Delan, and if you could take us a bit more deeper on both the evidence on how racism affects children's health, but also what are some of the successful approaches to address racism?
Thank you. And a lot of this does follow on from what Alejandra was just saying. So on the evidence, I think the first thing to say is that racism in and of itself is bad. It's bad in a moral sense, regardless of the health outcomes that we may see. And when I spoke about the limitations of the evidence, I think it's also clear that there is enough to say that this is a major cause of ill health amongst children. We know that racism can affect mortality and morbidity, and that happens across life stages. And as was just mentioned, it's present from birth. And sometimes people argue about illness being caused by bad behaviors of people, but we see this right from birth. We see that infants have a higher mortality than among certain groups. In the UK, Asian infants have double the infant mortality than white infants. Black infants have 3 times the infant mortality. So this is there right from the start. There's also, as was mentioned, increased risk of preterm birth, low birth weight, with all the subsequent consequences of those conditions. The slow quality care for minoritised women in pregnancy linked to high mortality. So black women in the UK have 3 times higher mortality than white women. And in childhood, there's evidence across a whole range of outcomes from mental health and physical health. Mental health, huge amount of evidence on the harmful social, emotional effects of racism on children and adolescents. A study from Australia looking at Indigenous adolescents showed that the population attributable risks, so the proportion of emotional behavioural difficulties related to racism, was 16%. So a significant amount of this big burden of illness amongst young people is related to racism. In physical outcomes, we see increases in inflammatory markers, body mass index, blood pressure, asthma, a whole range of physical outcomes related to stress, chronic stress in particular, that changes hormonal adaptations to stressors. But I also appreciate that when talking about racism, it's easy to sound abstract or aloof. So I thought I'll give you just 3 personal examples that try to exemplify this individual, structural and global health nature of this. The first is the individual pathway, so related to myself. Growing up as a young South Asian child in the UK, playgrounds can be quite unpleasant places at times that identify difference. And like many others, I've faced verbal abuse, particularly as a young child, but then physical attack as a young adult. And it's easy to see how these pathways can result in trauma, physical trauma, mental health issues. The second pathway is a more structural pathway, and this is how people are treated within hospitals. So in the UK, we have a hostile environment towards migrants. And one aspect of that is the charging of migrants for secondary care services. And these are charged above the normal NHS tariff. An example was when I took my son for allergy tests to the local hospital, and then I received a letter a little while after asking whether I should be paying for his treatment. And I thought that's quite odd, and I'm unusual in that I work on these topics, so I know a little bit about it, but most people don't. The average healthcare staff doesn't know what the rules are, let alone the general public. But then I also asked, why am I receiving this letter? And I think the only reason is my name. Mm-hmm. So this, what I would argue is a structurally racist policy, also has an effect beyond the target population. And lastly, there are many aspects of luck that mean that I'm speaking to you today, but one of these relates to my parents. So my parents come from Sri Lanka, and they were subjected to a targeted attack based on my father's ethnicity and religion. My father comes from a minority group in Sri Lanka. And one night, a mob went to their house and set it alight. And luckily, they weren't there at the time. But racism happens everywhere. This is a global health problem. And as Alejandra said, there are these increasing understanding of the intergenerational nature of this, stressful effects on the physiology, particularly of the mother, lead to hormonal adaptations, epigenetic changes that affect the unborn child. So what can we do? Unhelpfully, my response to this is always we have to do everything. And that goes from that individual level to communities, to the spaces that people live in, the institutions, particularly the health institutions, the systems, the structural nature of this. In our commission, we're looking at 3 different ways of doing it, and one is to apply a complex systems approach. We need to stop thinking about children in isolation. There's a phrase, it takes a village to raise a child. Equally, it takes a whole village or society to improve their health. There is no single silver bullet answer. So we're looking at a complex system approach, trying to first understand the whole system, how racism leads to health outcomes. And this helps us to think about the multiple pathways, the feedback loops, the positive, negative feedback loops. And so we can then look at interventions, groups of interventions across these multiple levels together. The second is to take a long-term approach. So we can't magically change societies built on centuries of divisive history. And I was speaking to one of our youth advisory boards in Haiti a few days ago, and we have to address the immediate consequences. But one of my comments was, some of these interventions are about improving the lives of your children, not just you. We need to think of these longer term perspectives as well. And then finally, I said that children are ignored. We need to stop ignoring them. Listening to children is part of the UN Conventions of the Rights of the Child. And there's been a push towards engagement with children, but often that relies on the charity of adults. I will speak to these children and take some of their views on board. But we can change this. And I would argue that children need to be considered within the political franchise. We're talking about a quarter of the world's population. This is not some small fringe group. There are many ways to do this, and it can vary by age, but we need to take account of what children are saying. We need to take a childist approach where we empower children, allow them to make decisions, hand over power to them. Thank you.
Thank you so much, Delan, for sharing both the personal and the evidentiary part, and lot to reflect on. And as somebody who's working with you on the commission, I cannot emphasize more the complex systems approach, and I hope we get to talk and hear from you a bit more about that, but just underscoring that point about this is where we do need everything, everywhere, an all at once approach to get somewhere with it. But Dr. Wazir, as somebody who's worked as a school therapist, as a lifelong advocate, and now as WHO regional director for one of the most complex regions, if I may say so, Southeast Asia Regional Office. What do you think we can do in order to address the systemic, deep-seated nature of the issues that we are talking about here?
Well, yes, I think many of the points that were brought up, there is a lot that we have to do, and I think within the healthcare system, where we have to actually start is getting an understanding of what the biases exist within our healthcare system. So when it comes to health, the health workforce, right? And of course, it's good you mentioned the personal story, because it's funny, we're on the same panel. So many of the experiences are very, very similar. I grew up in different countries, many different countries. I raised a family in different countries. And just to give you a little example, as a parent, going to the pediatrician, I didn't see pediatricians that were similar to me, that they could relate to me, that had any identity with my cultural background or any knowledge about my cultural background. And so if my child, and there were already belief system and assumptions that I had to deal with as a parent. So when my daughter had, 2-year-old daughter had hurt her arm, and we went in, the immediate, you could sense it, that, are you using physical punishment at home? Is that what happened? So imagine going there again, and you're fearful. Because if I go in too many times with injuries, they're going to think there is something not right, because the belief system is, in your culture, physical punishment exists. And yes, it exists. But is that what happened? But you're facing that. So am I going to actually go take advantage of the healthcare service that is available to me? And add to that if it's a family with financial issues, add to that if it's a family without good communication skills, or without the language requisite language skills. And what do you do? Are you going to access the healthcare system, whether it is a national healthcare system or if it's where you need to use an insurance, and you're thinking, okay, can I afford to pay the bills that are going to go? So there's just basic health behaviors that are very driven by our experiences coming from minority groups that we don't understand. So the attitudes and belief systems the healthcare professionals bring to the table are just, these are unspoken belief systems. When I used to work as a school psychologist, I had the opportunity for a short time working within a very wealthy, predominantly all-white neighborhood, and they would assume that at the time that all families, Hispanic families, were dark-haired and a bit darker skinned, and so they had one child who was very light-skinned, blonde hair, and they just sitting at that table, they just actually assumed that there was, she was an albino. And this is a conversation that's happening when you're making educational decisions, when you're trying to decide whether the child will be assessed for an academic need. So that is a behavior and a belief system that exists among people, among any of us that are living in that are not part of the majority culture. And when we have, let me just talk about even assessment. I did a lot of autism assessment, right? In autism assessment, one of the basic things is eye contact. There was always an assumption, if there were, kids that were black kids, that they're not going to make a lot of eye contact because they've been raised in families where making eye contact is considered disrespectful. So that particular behavior, which is fundamental to identifying autism, whether the child is making adequate, appropriate eye contact or not, was completely disregarded. Oh, they're going to not make eye contact because they come from this family where they're not supposed to. That isn't true. You will still have eye contact of a child that is very appropriate. Perhaps there's a bit more deference, perhaps there's more, respect that is being shown, but it's not going to look any different when it is communication. You will communicate, you can tell. And so it's training these, I think, professionals, one, helping them understand, introducing different cultures to them and how the different cultures communicate, how it's presented. And then also asking the tough question, like what are their own biases and belief system that they are not acknowledging perhaps, or that already exists and is going to impact how they provide services. So yes, I mean, if we really want to address racism within the health structure, we have to look at who are the ones who are going through medical schools and becoming professionals. And it isn't minority groups. Very rarely is it minority groups. There is a systemic bias on who can actually afford that kind of education and opportunities. So we're always racing against that. Even within our cultures, very few minority microcultures actually make it into the health system. So there is biases that exist. So how, unless and until we talk about it, unless and we have that opportunity, I mean, conferences like this could actually have sessions of health professionals here. Let's talk about the tough question. Let's be a little honest. We all have our biases. You have about me, I have about you. But if we talk about it, we're a service healthcare provider. Unless we change, unless we understand your culture, unless we make that effort, this is not an automatic set of information. It isn't there anywhere. It is going to continue to perpetuate those beliefs. And the longer we are in a system that supports that, we're not going to be able to change. So if we want to really change it, we have to change that conversation, talk about the big elephant in the room, and address some of these biases that we all carry.
Thank you so much. It's really amazing, that we have leaders like you in the roles that you play, and just stunning. And just to put it in context, I literally did ask her 10 minutes before to come into this conversation and join us, but just wanted to underscore the point. Let's be honest when we are talking about these issues and address our own biases to start with. Alejandra, David, over to you guys for the same question. So what do you think we can do? What can work? And where, from the regional policy and other perspectives that you have worked on these issues, how do we think? And you both talked about very distinct issues, as intergenerationality at one end, the complex structural nature of issues at the other. So maybe we start with you, Alejandra, and then to you, David, and then it's really open to the audience for their
Sure. Well, one of the things that we know it's starting to work has to do with something my colleague was referring to, right? Like the importance of healthcare, that interaction being with someone who it's of your background, or at least has a really strong like diversity background. But at the same time, I think it's the danger of just focusing on that would be what my colleague was saying, in terms of just becoming so identitary that a white doctor or a white OB would not be able to provide with good services, right? I think that there are structural conditions that we need to address. I think that if we don't address how poverty is racialized, like what are the systems that are in place that continue to racialize people, we're not going to change anything. The other point I want to underscore is this point of agency. I fully agree that one of the perils is that we approach this with women, with racialized groups, and with children in a way that is very protectionistic, and we are here to save them and do what's best for them. And that is just another way of perpetuating the robbing of power and of agency, and we continue to do this. One of the ways we've done it historically in our movements is through the use of criminal law. That doesn't work. That only continues to aggravate the issue. We need to think in terms of agency. I 100% agree. We need to think of agency of children. Children should have agency. We need to give back women agency in their childbirth and pregnancy experience. We need to get away from the thinking like this. There's a victim and there's a perpetrator, and we're gonna solve this by punishing all the people who are being racist. Because as I think we've all been discussing, like this is so structural. It lives in all of us. Like it would be a lie to think that it doesn't live in all of us. So I think addressing structural conditions, thinking about agency and giving power back to where it belongs, and education, which is something that was already mentioned. Like we need human rights education for our children, which our children need to have these discussions, and it starts there, and hopefully it goes all the way to higher education, but I think it starts there. Thank you.
Thank you, Alejandra. That was remarkable. David,
Yeah.
you know something about shifting power in global health. So what will it take?
Well, I think we really need to understand where racism comes from, and really to try and understand its roots. And I think the most harmful and destructive forms of racism, the structural racism that is embedded in political and economic structures, is really a racism that is created. It's been instrumentalized in order to enable these exploitative and oppressive political and economic systems. You know, I've always been quite taken by the history of the British East India Company in India. The first 100 years of the British East India Company in India, there was very little racism. In fact, it was the opposite. Many of the officers of the East India Company admired the Indian culture. There was a lot of intermarriage. It was only when the relationship changed to one where the East India Company sought to dominate and subjugate that racism came into play. So racism was created, it was instrumentalized in order to enable this colonial endeavor to expand and to allow, provide some kind of legitimation for this domination and subjugation and oppressive behavior. So what's the antidote for that? The antidote for that is surely about democratic systems that are able to hold power in check, that are able to hold power accountable. So one of the key tools for combating structural racism has got to be democracy. And by democracy, I mean a sharing of power across all people, an antidote to autocracy, an antidote to colonialism, an antidote to plutocracy. So we've got to be thinking about democracy, and we've got to be thinking about how democracy is eroded across the world in the last 30 or 40 years. The second thing is also to consider racism as an outcome. So we have racism as a means to do things, but racism is also an outcome. It's an outcome of fear. It's an outcome of insecurity. It's an outcome of being impoverished and living in a world where you can see other people with wealth. So we also need to be thinking about how we can reduce inequality as a means to reducing racism, because deprivation, not just in terms of material deprivation, but the deprivation that people have in terms of having access to truthful information is in itself a problem now, creating social divisions and hatred and racism. So I think, again, we need to look behind the curtain and see racism as much as a symptom as it is also a cause of health, illness and inequalities.
Thank you. Thank you very much, David. That wonderfully said. And you know, both bringing in the ideas about democracy and sharing power, but also linking racism with different forms and structures of inequality. Colleagues, over to you. I'm sure there are reactions, comments, manifestations. I see several hands going up. I'll try and take them in bunch. So bear with me. I'll try and cover them all. We've got enough time. So let me start with you, ma'am, at the back.
Yeah, thank you. Dersim Dadevren from Germany-based network of Kurdish academics. I will give an example from Turkey. On the one hand, we have the discrimination against children from the Syrian community, which had to flee to Turkey after the war in Syria starts. But within Turkey, we have also a serious racism against the Kurdish community and the Kurdish children, because there are still many women who don't speak Turkish or just a little bit. And if they go to hospitals or doctors, especially in the non-Kurdish majority areas in the western of Turkey, then they face really racism because they don't speak the language very well. They don't speak Turkish very well. And in the Kurdish majority areas, we have mainly Kurdish-speaking doctors, but these areas are economically neglected, so that we have other problems in the health system. And all these problems which children are facing, especially, for example, in the Kurdish-dominated areas, we have just one pediatric oncology. And this is very serious because 15 million people are living in this area. And Turkey is a candidate to the European Union and also a NATO member, so and a democratic country. So it's the kind of democracy which is important for the fight against racism. So I agree with the last fact you mentioned, that democracy, real democracy, is very important. And the other thing I want to mention is, for example, we had their mayors in the Kurdish cities, Kurdish mayors, and they tried to improve the situation, but then Ankara decided to implement trustees in these cities and dismissed the Kurdish mayors. So we have really a problem which all Kurds in Turkey are facing. Thank you.
Thank you. Thank you very much for that intervention. I'll come back to the panel and I'll take questions in batches of 3. Please go ahead. And I'll come to this side of the room. Next is just one microphone we have.
Good morning, everyone. My name is Dina. I'm from the Yield Hub. I'm the program associate there. So I have a questions. I mean, like, we're talking about the children in here, and then, like, I think the most important thing is that we have to listen directly and meaningfully to the children to solve these kind of issues in the racism and so on and so forth. I mean, in this era of like AI and everything is easy, there are a lot of organizations that saying like, yeah, we are meaningfully engage young people. But eventually, sometimes rather than literally put them into account and then meaningful engaging them, they're just like exploiting them. Put them in your own report, for example, for the next 10 years, putting the pictures of the children and so on and so forth. But then into the decision-making process itself, they don't really like engage them. So like, I would like to address like, how can literally all of us here, I mean, we are all stakeholders here, we have power in here, how to change and then like change the norms itself within our own organization to rather than only exploit children, but then meaningfully engage them without tokenistic way, also manipulative way, so that at the end of the day, the children itself know that they have the agency, that they know that they have the power, and we can also have the youth-adult partnership or children-adult partnership, because at the end of the day, sometimes the lack of the, the audacity from the adult as well to want to listen to the children, because no, you are just children, or when they would like to give the participation and opportunity, they would only choose the children that only speak English, for example, from Indonesia. I'm like from Indonesia, they will be like, no, you are good and better for PR machine making, you know, because like you can speak everything easily without needing like the translator. So how we all in here can literally indulge that and then also change that in our own self or also our own organization. Thank you.
Thank you. Very good question. And I'll take the hand up here, and then we'll take the next round of questions.
Kia ora, hello. My name is Alana Ruakiri. I've come here 40 hours flying from New Zealand.
Wow.
I hope everyone knows where New Zealand is. I am Indigenous Māori, and I'm perhaps the only Māori here at this conference. I manage a health and social service. It's quite large. It's owned by 8 iwi, which is our tribes, and we are a colonised country. And since 2010, we've had an amazing policy platform called Whānau Ora, which is a very holistic approach within Māori health around treating the family, the whānau unit, as a unit and bigger than that. We've had a recent change of government, and our government is based on the Westminster system, and cabinet paper was recently circulated removing ethnicity as any means of assessing need, which I'm reeling from, which is why I came 40 hours on a plane to hope to understand if others have been through such a radical shift in policy settings. And having worked in the public service, I understand the power of that shift in a policy, and I'm kind of devastated and flabbergasted. And I'm a real fighter for our people, but on every indicator you can think of, Māori children do very poorly, as do Māori adults, and we live, our life expectancy gap is 7 years.
Wow. Thank you. Thank you for your intervention, and thank you for what you do. I'm going to look at the panelists in case anyone wants to go in that order. Delan, would you like to respond?
Sure. So just on that last comment, we have a colleague within our commission who's doing a case study around New Zealand, and she's from the Maori community as well, so I can speak to you after. And yes, this happens in New Zealand, it happens in Australia, it happens in Sri Lanka, as I mentioned, it happens in the UK, it happens everywhere. Marginalised communities are marginalised, they are put down, they are subjugated, and they face the worst health outcomes. We see this across the world. On the comment of listening to children, I agree with that comment. It's a shame that Hazel isn't here, because she's doing this kind of engagement work, and she could speak much better than I can. And I know another colleague of ours, Ananda, is in the audience, who actually does this work, engaging with young people as well. And yes, it can be exploitative, and it can be we are using these children to tick a box sometimes, and because we have to. And that's why I kind of think, I think it's important. I think we have to do engagement. I think we have to listen to children. But can we shift that a bit more? Can we actually give children, young people, decision-making power? Can we hand over decisions to them? And maybe we don't agree. I often disagree with my 8-year-old, but there are things that she can decide. There are things that, there are decisions that an 8-year-old can make, a 12-year-old can make, certainly a 15, 16-year-old can make. And what I would do is give them voting rights and let them make decisions.
Thank you, Dylan. There are several things my 11-year-old wants to do that I disagree with, but do you want to...
Well, I think what's kind of being brought up with we're running with this assumption that we're a very homogenous kind of health system, homogenous society, and the reality we're a very heterogeneous society. And I definitely agree with the idea of giving children greater agency. the idea of when childhood ends, like when are they considered adult? When can they make decisions? When can they speak? Like, traditionally, a lot of 9-year-old and a lot of communities, 9-10-year-olds had to take a lot of responsibility. That's how our communities really were. I grew up where, for various family reasons, by the time I was 9, I was living with my aunt, actually, and not living with my, and she had 2 children, a baby. And I was very much, helping with the chores in the house, helping take care of the baby. And in fact, the story is, which, my cousin who's 9 years younger and is a bit of a know-it-all. I remind quite frequently that I used to change his diaper just to sometimes, level the playing field. But it was these kind of responsibilities that we used to give. And nowadays we kind of consider children like the recipients of healthcare. We don't really listen to them. And in fact, due to a lot of availability of information, due to social media, they actually are much more verbal. They're much more knowledgeable. And sometimes they get a lot of misinformation, but they're very vocal, very opinionated, very informed. If you bring a group of 12 and 13-year-olds, beware, because they will school you, they will teach you. And yes, I think we have to create those opportunities, actually learn from them, give them the tougher questions, raise the expectations. Because we're providing that from an education point of view and learning opportunities, but we're not involving them in decision making and in creating that space to hear from them directly, to see how the system is biased against them. And what else needs to kind of change. So that's, I think, a good place to start. I realize I'm doing one thing. I keep thinking of like a circle, and psychologist in me is like group therapy. If anybody's a psychologist here, it's like, let's have a conversation about everything. But I think these kind of sessions, and thank you for organizing and bringing all of us here together, talking about children, talking about racism and the healthcare and biases against children. This is where it starts. This is where we have the health leadership has to begin to take that change. So we all have to kind of work towards that change together.
Thank you. And thank you very much for situating that within the larger conversation, Saima, that we need to be having. And just a brief example before I turn to you, Alejandra and David, is, I work with the Partnership for Maternal, Newborn and Child Health. And for us, the issue of meaningful youth engagement is to the core. And I have my governance chair sitting in the front row. And I think she should be given all credit for the way we are structured today. One of our vice chairs is under 30. And across different bodies, we have representation, and it is meaningful. But I think the challenge for us is, how do we take it to the next level? And what that would look like. And I think this is where we need to be constantly working on these issues and not take them for granted. As our colleague from New Zealand mentioned, when you have the state fabric then starts to water down legal protections, what do we do? What do we do when basic guarantees and human rights are being taken out? I think we have a challenge, and that's just, I just wanted to add, that's happening in the country context that you spoke about, but it is happening systematically, that there is a move that is there to water down some of these issues so that, they are indeed tokenistic now at best.
Yeah.
Alejandra, David, any reflections before we come to the next round of questions?
Yeah, I'm going to say something a bit controversial for a human rights lawyer, and it's that I think that in this issue of agency, which I'm very happy to hear all of you very much campaigning for this, there's been a downside to this concept of the best interest of the child, because the way it's being commonly used is, I know what's best for you, so I'm going to tell you what's best for you. And I think that we need to take cues from what the disability rights movement has built in terms of assisted decision-making, in terms of how we equip children with the tools, the information, and trust them, that they are logical, rational beings. And I'm obviously not saying that there are no evolving capacities. We cannot ask my 2-year-old, some of these things, no matter how much I assist her. But we definitely can have so much agency and respectful interactions, both at the family level, both at the policy level, if we approach this from a different perspective in which we understand there are evolving capacities, but in really centering agency, we look at it more the way that the disability rights movement has looked at decision-making, that this protectionist way of in which sometimes the best interest of the child has been used.
David?
Yeah, I just want to come back, just listening about the issue with the Kurds and with indigenous tribal peoples all over the world. You know, the critical importance of universalism in the sense of the universalism of common human rights, that all of us, regardless of our background, have access to basic fundamental rights and freedoms. And I want to use a quote from Susan Neiman, a German philosopher, who said that without universalism, we have no case against racism. We merely have tribes, different tribes jockeying for power. And so this universalism is what provides us with an argument against racism. And we somehow have to find a way of reinforcing those universal values and principles, which are eroding. I mean, we're currently witnessing a televised genocide go on with huge racist undertones. What provides us with an argument against racism, but it's also got to be done in a way that allows for the cultural, racial, and ethnic diversity that's also important. And that tension is a critical and important one.
Thank you.
I don't know what the answer is. I don't know how we achieve it. My father used to say to me, let's get everyone speaking English. In his mind, he thought that if we all shared a common language, we would be able to find more common solutions to our common problems. I'm not sure I agree with him, but anyway, these are some of the practical challenges that we have right now, and especially as the resources that are available to us, planetary resources, dwindle, we're going to have to learn how to share. Otherwise, racism is going to get bigger and worse and more violent.
Thank you, David, and for literally underscoring the point about universalism and values. I see there are 3 hands there, and I'm going to come to you, Ananda. I know you're trying to hide. But let me come to this side of the room. Sir, you've been waiting for long, and then we go back to that side of. So we'll take these 3 questions. Madam at the back, you, please. No, I'm sorry. I'm not being very clear. The gentleman with the suit. Yeah.
Thank you very much. John Coughlin, International Cerebral Palsy Society. I wanted to pick up, thank you very much, Alejandro, for mentioning disability several times, in different contexts. And the connection you made between maternal health and child health. We know that the incidence of cerebral palsy, the most common form of childhood onset physical disability in low and middle income countries, is much higher than in high income countries. We know that in the United States, the incidence among African American children is higher than among the rest of the population. And so, Rajat, as you said in your introduction, that's not natural. There are other explanations for that. And so in terms of long-term health impact, thinking that this is lifelong disability, sometimes very severe disability, and it can be traced back to issues of maternal health, access to good perinatal care and so forth. And then to think about the intersectionality of that going on, to be in a racialized group, to be in a racialized group, and to be disabled, it gets more and more severe. So I would just appeal to everybody working in this field to keep that focus also on disability as a lifelong impact.
Absolutely.
Thank you.
Yeah, thank you so much. Paulina Hassenteufel, she, her. I guess it's very fitting that we're sitting next to each other because I'm myself chronically ill and disabled, and I'm white. I have never experienced racism. I grew up in Berlin. I've since moved away, but I've been very privileged. I grew up in a very academic family. But I did not have anyone in my family who is disabled or chronically ill. And I also didn't get diagnosed until around 20 with some of my diagnoses. And some of them are still ongoing because even though I live in a high-income country, as a chronically ill and disabled person, the health system is not made for me, which is ironic because most of the patients are chronically ill and disabled. And even though I have never experienced racism, I related a lot to a lot of the stories you've told. You've never had a pediatrician who looked like you. I've never had a doctor who looked like me, who was disabled. I've studied medicine. I've been active internationally in the IFMSA. Most of my peers don't look like me. Most of my professors doubted and have even asked me how I think that I, as a disabled woman, could become a doctor. I've had to quit medical school, even though I was studying in the Netherlands, a high-income country, because of the incredible ableism that I faced by medical education. So I agree by saying the system, the healthcare system, is only going to be changed if people, minorities, are going to be part of it. But the reality right now for a lot of people, especially for minorities, is that we cannot. Even though I'm incredibly privileged in my disability, I'm academic, my dad is a professor, my family has a generation of doctors, but it's still not possible for me, no matter the privilege, to finish medical school and become a medical doctor because it is so, so flawed. And my question is that all these experiences, be it cerebral palsy, be it racism, we all agree in our stories and we have the same experiences. The data is similar. If you look at ableism in healthcare, I was nearly not able to make it here this week because I experienced so severe ableism visiting my GP on Tuesday that I have had panic attacks ever since, which is not rare. This has happened. This is a regular occurrence for me, and non-white friends have similar occurrences when they visit their GP, and it's just unfortunately normal, and other people can't relate that. This is not just studies, this happens to me on a weekly basis. I've been discriminated at the UN headquarters in Geneva during WHA by staff. Those are not jokes. They are lived realities of the people who are in these positions and still have the privilege of being here in these spaces. I'm a public health and disability advocate, and I also receive letters from my health insurance with letters from this is high-key illegal what you're doing, and I, as someone who's kind of an expert on the topic, would like to go to court with you because what you're doing. But no other patient knows this, and I'm only able to fight it because of that privilege. So coming back to my question, because I'm talking a long time, is how can we, as minority groups, work together? Because the experiences are so similar and so shared, and it is a systemic issue. Ableism is also supported by the capitalist finance system. It is also rooted in it. And how can we bring these communities together to not just work on them separately, but unite our forces to untackle the system which systematically discriminates all of us at the same time with the same effects? Thank you.
Bravo. And thank you. Thank you really for bringing not only, your lived experience and reality, but the desperate need for allyship across our movements, and for us to come together to address the kind of structural discrimination and impediments we feel. And I hope the room is able to reflect on that as we come to a close in a few minutes. I think we have got time, just enough time for one more round, so I'm going to request the panel to request their responses to be brief, so we can have one more round of questions. But over to you first.
Hello. Yeah. Hello, everyone. My name is Pragati Gupta. I'm from India. I am representing one non-profit organization, the Hues of the Mind, which address the mental health for everyone. So I have few comments and few questions for everyone. The first comment is like, recently I have seen one survey where the small children's around age of 5 to 8, they have been asked if they would like to change one thing about their body, what will be it? And the same question has been asked to a teenager, and the answers were shocking because the teenagers' answer were like, I wish I would be a little bit more brighter. I wish I would be a little bit thin. I wish I would be something that they really want to change. But if you see the answers of small kids, they were like, I wish I would have wings so I could fly. Or some answers were like, I don't want to change anything. I think I'm perfect. So I really think like what really changed in between this age that led them think in that way in a teenage that they want to change something about their body. They really think that something is wrong with them. So what, how can we address this at that early stage for them? And the next comment is for the healthcare professionals. I have my friend, he have one experience that he have went, he lives in Germany. He went with his child to a health hospital, and their staff was like, if you cannot speak our language, we cannot treat you. Like, we don't know what you are saying, we don't know. I don't know, this should be education, as she told, should be provided to them, that they should treat everyone equally. It's not like maybe it's a visitor or they are not aware with the language, so they don't discriminate on that basis. And the second thing, I agree with her as well, that she said there should be agency for children as well, so that we will know what they feel and we work for them and made for them. And the last thing regarding democracy that can address, it could be in a large scale, but my next question is how it could be addressed to the countries who are not democratic. So I have these several questions. Thank you.
Thank you, and I hope you are able to engage with the panel and others afterwards as well, and
sure.
that we can get
Thank you.
Any brief reflections from the panel on this side? Delan, Saima, anything from you?
And all I'd like to say is that this is really a great start. I see this as a start of a conversation, of some change that will begin. I hope it doesn't stop at just this. It's taken up because clearly it is something that is impacting all of us. And the definition of racism certainly has to change, because it's not just about the cultural community. It's just being a minority, being not a part of the larger group and being misunderstood. So that would be my one big request. It's a complex issue, but it can be addressed. This is just a start.
Absolutely, and we'll have a chance for panel to have their final reflections. But any response, Delan, from you for the three interventions we just heard?
Just very briefly, thank you for sharing your personal experience, and also talk about cerebral palsy, disabilities, and ableist mindset, how this affects people with disabilities, but everyone, actually. That's incredibly important. I don't have a wonderful answer to bring people together. I think hopefully if people can appreciate what's happening to that other group that isn't their own, I guess through increasing conversations you can start to make these ties to draw together the many different groups who are disadvantaged through the system that they live and work in. I don't have a good answer for how to fix democracies, I'm sorry.
I really wish
I think David will.
David probably will. He's just thrown Go ahead.
I think a lot of what we've been talking about is about our humanity. And I remember talking to a bunch of students at Queen Mary University London where I was working before, at the height of the Black Lives Matter movement and just after the George Floyd killing, and talking about racism within England, within the university. And I remember saying, guys, I think probably the most important difference that we should be thinking about amongst society is the difference between people who are kind and generous and decent and honest and empathetic versus those who are not, versus those who are greedy, who are violent, dishonest and unjust. And I think it's that reminder as well that we have to fight against the bad things as well as fighting for the good things. So it's just that reminder about humanity and thinking about, dividing up the world in those two groups rather than according to our race or our gender or sexuality. All of that is also important, but let's just think about those people who are greedy, violent, dishonest, and what we can do to constrain their power.
Thanks, David. Aliane?
Thank you. I really like the framework that Loretta Ross has used in the United States. And this idea that sometimes you call out and sometimes you call in. I myself have had the experience of being raised by a feminist and thinking that I was what we call woke, right? I really thought of myself as someone really woke, and there was so much talk about human rights growing up. And then I realized, even though I come from a biracial family in Colombia, how discussions of race were never had. And it was only later in my life that I realized, wow, like there is racism even in this family where we think of ourselves as such progressive. And then I became a mother, and I have a son who has a disability, and I realized how much ableism lives in me. And I am a human rights lawyer who has thought about these issues, written about these issues for so long. But it's only being through living experience and really being able to interrogate myself and realize that I am not exempt even from misogyny. That's what I was saying before. Like, I think that if we are honest with ourselves, we're gonna realize that these things are in all of us. It doesn't matter how wonderfully awake we think we are, how much we have think about these things, we are going to end up at some point or another reproducing them, even if it's in a very small scale. So I am convinced the older I get that we are only going to really address these things if we call in more than we call out. And part of calling it is really looking in. And I think that I don't have an answer for that democracy, but I do think that the revolution starts with small things.
Here. Thanks for that, Pascal.
Great. This has been it's been a really amazing conversation. I want to go back a little bit to the notion of children and what it is that brings this topic to the fore in terms of the age, specifically the age issues that we're talking about. I mean, if we just take children, I mean, I had a conversation with a colleague about, I don't know, I speak 4 languages, I don't know in any of the 4 that there is a word for children that doesn't still make me my parent's child, and I'm not young. But there is, and I think it speaks to the intergenerational issue as well, but more specifically, the notion of consent and what that means within, because that's not something that we have really addressed here yet. And it is a particular issue for me at the moment. And just to make a full disclaimer, we are not, in WHO, we are not looking at trans health for children. That has been the big thing that's been a problem for us. So we are not doing it, but we are not doing it, and this is the issue, because at the moment it's too complicated to think about about children's agency within that particular age group. So we have kept the guidelines to adults. Now, but what is it about? I mean, we've had conversations here about the age and giving children voice and so on. But we're not, I think we're not quite there yet on being able to solve this issue. And the fact that we are avoiding, because of, I won't put more information there, but the fact that we are avoiding looking at children is in fact perpetuating the problem, because then you end up with young adults who have serious identity issues that we can't provide the clinical guidance for because it's not acceptable.
Thank you, Pascal. And then also bringing another layer of intersectionality that we need to bear in mind. Colleagues, we are indeed running out of time now. I want to give the panel, 1 minute each for any final reflections, takeaways, and then we will conclude for the day as well. Let me start from this end. David, starting with you.
Sure. I mean, I suppose my emphasis has been really on the structural determinants, the structural. So, we can do what we can within the parameters of the kind of structures that we currently exist, and we should do that. But I do feel that we're not doing enough to address those more upstream structural dimensions. And we talked about universal values. I've talked about democracy. All those things are really important. I would just want to say about democracy, Rajat, democracy is not about voting once every 5 years. Democracy is about having a whole variety of social and public interest institutions that are able to kind of confront and mitigate the abuse of power. They include research, academics, they include a free and independent press and media, and so on and so forth. These are all social institutions that are part of a democratic fabric. And so all of us in public health have a role to play in making sure that democracy is healthy. And in those states where you don't have democracy, where you have authoritarian governments, there is nothing to do but engage in the struggle for democracy.
See, he did have a solution for democracy. Alejandra.
Thank you. I'll leave with this reflection on agency. And to me, that actually it's about the concepts of capacity and consent, right? Who we deem capable of deciding and what? It's often through the lens of racism, capitalism, ableism, right? Like all forms in which we marginalize people. But I just want to be clear that in my pitch here for agency, which I've done through the panel, that I think that that true agency also will only exist when we have addressed the structural, because otherwise it's just going to be for those who have the privilege to actually exercise it.
Thank you, Alejandra. Delan.
So thank you very much for organising this session, Rajat. I think on the question about consent, probably there's no time to go into it, but I'm happy to spend a few hours speaking with you afterwards if you'd like to. And just reflecting on other members of the panel, just something I thought of is this sort of micro and the macro, the looking inwards, thinking about yourself as well as the actions that you do, but then thinking big, how can you make big changes to society? So that's something I've taken from my colleagues. And just to thank all of you for joining this session. If it's a request that I can have to all of you, take back these ideas, take back these issues of racism, how it affects children in particular, the families, the societies that they live in, and apply it to whatever you're doing. I think that's where it can really spread out and have a big message.
Thanks, Delan.
Thank you for that, for bringing me in to speak about this panel that I was completely unprepared to do. But I think I've made some valuable comments. One of the things that taking on the position of regional director and a lot of confusion that was caused in my office was the idea that we did develop this roadmap, right? Because the challenge when we work in health systems is we're looking at eliminating diseases, but we're not actually looking at what the health infrastructure looks like and how we can make the health infrastructure much more equitable. But at the end of the day, the main issue of this topic is this recognition that it isn't equitable, it isn't the same. And at some point, we have to find how to make it equitable, how to address these issues, create a plan, and also how to make set ourselves goals and objectives that are measurable. So now we're not just talking and having these kind of sessions, but we're doing something one small step at a time, particularly when it's something so strongly embedded and so complex and varied. How do we actually go? So the request would be, let's start working on that, looking at the health infrastructure, not just from disease and a marginalized group, but from this perspective, where is it inequitable for children? Where is it inequitable for groups that are marginalized? And then develop a mechanism for measuring our progress so that we're slowly progressing in the right direction.
Thank you so much, Saima. And colleagues, I'm not going to do a lengthy summary because I'm also being shown that we are almost out of time. But we heard a lot today. We heard about the need and the power of allyship, focusing on our shared humanity. Thank you, David, for mentioning, be kind, be generous, be decent, be empathetic. If you're going to take one thing from this panel, take those values to every conversation that you travel and the work that you do, and call in, call out, but call in first before you call out. And really thank you to all of you, to this amazing panel, to you especially, Saima, for joining us. And let's continue the conversation. Thank you.